and foremost, thank you all so much for being here this evening. My name is Brooke McGivern. I am a speech pathologist and the director of marketing here at Tim's Medical. I am super excited and honored to introduce our speaker for this evening, Sara Davis, who will be providing the presentation, a deeper dive into SLP-related management of ILO, EILO, and BPD. A few housekeeping items before we get started. This course is eligible for 0.15 ASHA CEUs or 1.5 PDHs. If you are interested in earning ASHA CEUs, we ask that you stay for the entire duration of the course and that you complete a brief survey within 7 days. So I will put the link to that survey in the chat. It will also be sent out via Zoom emails. If you have not subscribed to those, don't worry. Just send us an email at tims-unum@tims.com and we can send you the link because I know some people are logged in on their phone. And of note, we will close that survey next Monday, January 19th, so that we can submit your information to ASHA. This session is going to be recorded and the replay will be available on the TIMS website within 48 hours, which will allow you to review all of tonight's content. If you have questions throughout the session, please put them in the chat or the Q&A and we will address as many as we can prior to the course conclusion. With that, I'm going to hand over the floor to Sara.
Hello, everybody. So glad you're here. I'm going to go ahead and share my screen. Oh, maybe I'm not seeing what I need to see. Let me pull this up a little. Okay, let's hope that works. Yes. Okay. Sharing here, and I'm going to all right. Alrighty, here we are. So a deeper dive into SLP-related management of ILO, EILO, and BPD. And we have a lot to go over, so I hope I keep your attention this whole time. There will be time for Q&A at the end, and I'm happy to stay later and keep answering questions as needed. I know it's a little later for you than me. I am in Arizona time. There are some disclosures here, and our objective, as stated on the website when you registered as well. I won't take time to go through them. We'll certainly cover them throughout the discussion. It's a little bit about me, but I think Brooke did mention that, and you saw my bio as well when you registered. So I do work with airway conditions every day with several patients per day, and specifically these three conditions, along with a lot more. And so our talk today is just focused on ILO, ELO, and BPD, aka DB, which we'll discuss more, and kind of the concept of the unified airway as well. So, airway related conditions. There are many, as mentioned. Today we are focused on ILO, EILO, and BPD and/or DB. And we will also talk about what else could impact airway, but more in a nutshell. I did another talk in June. It was a little more comprehensive, but also a little more nutshell. And now we're diving in deeper on these topics. So, therapy for these conditions and airway in general, yes, but there's so much more we must know first. This presentation will definitely cover it. Airway therapy is very beneficial. There are several ways we can address therapy. Airway conditions normally respond well to therapy-related approaches. However, if there are upper airway obstructions or other anatomical conditions, surgical intervention may be necessary first. So again, that's covered a lot in the previous talk, but we'll touch on that a little. Breathing in general. Breathing is without a doubt the most consequential of human behaviors. Breathing not only sustains life, but interacts with many other body processes, such as posture, motor control, fluid dynamics, in blood and cerebrospinal fluid, voice and speech, cardiovascular functions, the nervous system, and gastrointestinal activity. Normal breathing function at rest. Functional breathing is breathing that supports primary and secondary functions of breathing. Primary include the biochemical and biomechanical functions. Secondary include posture and motor control, speech and voice, etc. Dysfunctional breathing, DB, can be defined as breathing that does not support the primary or secondary functions of breathing. The basics, as you all likely know, during normal at-rest breathing, the vocal folds open to allow air to pass into the lungs where the gas exchange occurs. During normal swallowing, we know the vocal folds protect by closing. And during normal voicing and speaking, the vocal folds close gently, and air passes through them to cause the vibration, which results in a buzz. That is the voice. Because of that buzz, the sound comes up and out our articulators and our resonators to give us all our own voices. Now, again, this is nutshell. Breathing. It's an important part of the scope of practice for most SLPs, especially those that specialize in voice and upper airway. Many upper airway SLPs only interact with breathing as it relates to voice or laryngally based breathing disorders. This emphasis on the upper airway could be problematic considering we cannot functionally separate the upper and the lower airways. And I love this quote, and it's from Newer Research, 2025 Perspectives article. There were several that just came out at the end of the year, and hopefully you all saw those if you're interested in this. But I suggest you checking out that. It's in SIG 3. And you can still access it, but expanding our scope to the unified airway, which some voice and upper airway SLPs have already done. This allows us to support a more diverse client population, such as those with OSA, long COVID, asthma, COPD, etc. So again, here's a quick question here. And there was an article specific to OSA and SLP involvement in this perspectives group that was just published. But OSA, we would think, okay, is there really a role for the SLP here? It's a prevalent breathing disorder characterized by repeated upper airway obstructions during sleep and sometimes usually leads to sleep fragmentation, intermittent hypoxia, etc. SLPs possess, and this is from the article, specialized knowledge of oral and pharyngeal anatomy and breathing mechanics, which provides them the opportunity to be key contributors to multidisciplinary approaches in treatment of OSA. And recent evidence supports efficacy of behavioral interventions, including myofunctional therapy, respiratory muscle training, strengthening the oropharyngeal muscles, improving breathing patterns, etc. So this can reduce OSA severity as well. Breathing, again, functional breathing disorders can coexist with functional voice disorders and LBDs, another acronym. But again, in this recent research, laryngeal breathing disorders, suggesting that dysregulation of respiratory control simultaneously affects both the upper respiratory tract and the lower respiratory system, which again leads us to the unified airway, which is kind of a newer topic and a wonderful one, in my opinion. Dysfunction of the upper and lower airways is likely to occur together, and this idea supports the use of multidimensional and multidisciplinary treatments that address the upper airway function and function of the whole breathing system. So this again is about the entire unified airway, and it's important SLPs have knowledge in the upper and lower airway systems so that we can treat the patients in a more holistic and efficacious way. There are now case studies showing positive treatment outcomes after comprehensive assessment-based breathing retraining, which addresses multiple dimensions of dysfunctional breathing. It's important to consider the unified respiratory system, again, both lower and upper airways, and multiple functions of breathing in the evaluation and treatment of these patients with laryngeal breathing disorders, LBD. The connection between dysfunctional breathing, DB, and ILO, more specific to the upper airway, which we're going to get into, suggests that the established clinical characteristics of DB, fatigue, muscle discoordination, respiratory inefficiency, blood gas disturbances, etc., may also be present as underlying mechanisms in ILO and EILO. Integrative breathing therapy, also a newer concept and a wonderful one in my opinion. It's a patient-centered approach used in treating DB, which may be applicable to individuals with conditions commonly addressed by SLPs. Principles of IBT, integrated breathing therapy, are those that revolve around multi-dimensional nature of respiration, the unification of the breathing system, upper and lower, and the ears model, which again is from this newer research, and we'll get into that as well. IBT, functional multidimensional paradigm, suggests that effective management of LBDs requires practitioners to recognize and address the biomechanical, biochemical, and psychophysiological factors alongside poor breathing habits such as chronic mouth breathing. So, biomechanical, this involves muscle use and posture essentially. Biochemical, relating to gas exchange and regulation of O2, CO2, and pH. And the psychophysiological concerns stress response and emotions, and how maybe patterns of tension set in as a result. The ears model to determine whether breathing is functional for any given situation. IBT, the integrative breathing therapy model, suggests this acronym, yet another acronym, right? Five key features: efficient, minimal effort to meet the body's needs; adaptive, breathing should change in response to the demands of different situations; appropriate, it should be suitable for this specific context, whether at rest or in activity; responsive, it should respond to shifts in emotional or physical states; and supportive, breathing should support both the primary and secondary functions of the body. So again, LBDs refer to conditions in which respiratory symptoms arise from laryngeal dysfunction. These include ILO, and I'll just say, I'll use the acronyms from here on out, but you likely already know, but that's inducible laryngeal obstruction, exercise-induced laryngeal obstruction, ELO or EILO, and other terms often used interchangeably, including, which you may have heard or you may hear from physicians or other referring colleagues, VCD, vocal cord dysfunction, PVFM, paradoxical vocal fold motion, PVFMD, etc. So, and the D stands for disorder. But nowadays, the nomenclature truly has evolved to ILO, ELO, and then again, moving on to DB and BPD, recognized as an extrathoracic subtype of dysfunctional breathing, DB, or breathing pattern disorder, BPD. These conditions often benefit from treatment protocols incorporating breathing exercises, and we'll get into more of the differences. But essentially, DB is a little more general than BPD, but most people do use them interchangeably. So the roles of the larynx at caveman status, cavewoman status, I always say, the gatekeeper and protector role is top priority. And I always tell patients with these conditions, also included here would be irritable larynx or chronic cough or cough hypersensitivity syndrome, CHS, is just to remind people their airway, their vocal folds, their main job is to protect at caveman status, right? And so that's why in these conditions, it's thought to be paradoxical or abnormal of what it should be doing. But at baseline, they are protecting. They are thinking they're doing the right thing. It could be in response to a trigger or some kind of stimuli, or maybe exercise, or maybe stress, or whatever, reflux, but they think they're doing their job. Again, other roles of the larynx, the respiratory modulator, production of voice, cough, and swallow. So, ILO, here we go into our first contestant. So, a long definition here, but essentially, ILO means an inappropriate, transient, reversible narrowing of the larynx in response to external triggers. So, this has evolved to be more of the correct nomenclature, but you'll still hear it called VCD, PVFM, etc. It's a complex disorder of the upper airway that requires skillful differential diagnosis, and failure to acknowledge the critical role that this differential diagnosis plays can really cause issues of, long wait times to figure out what the real diagnosis is, costs, frustration, etc. And we'll get more into that as well. Per the Delphi study 2023, definition of ILO can be made when there is verification of inappropriate, transient, reversible laryngeal narrowing in a compatible clinical context, meaning the patient has symptoms. So again, functional laryngeal obstruction without any apparent structural or neurological etiology. It's distinct from asthma and other upper airway conditions. But again, that differential diagnosis is huge right here, because it often goes misdiagnosed as asthma for a length of time. It's characterized by inspiratory breathing difficulty with or without stridor. It's transient in nature and accompanied by a feeling of constriction most of the time at the level of the larynx. The patient may present to the emergency department and can be misdiagnosed as asthma and anaphylaxis. Patients may have as many as 3 or more concurrent diagnoses with this condition as well. Laryngeal edema, allergy, mast cell activation syndrome, panic attack, asthma, etc. All of these are considered ILO mimics that do affect the upper airway. Most patients with ILO will have had extensive medical workup and they may not believe an SLP can help. And so they may come to you frustrated. They may have seen a variety of different providers, sometimes upwards to 10 people before even seeing you. So they, again, could have their doubts. And it's not always a good place to start, right? ILO occurs through the lifespan in young children through the elderly. The greatest incidence is within the adolescent and adult age groups, 4 to 8% of the general population. About 25% of adults with ILO do have co-occurring asthma. And it's important to distinguish between ILO from an environmental trigger and angioedema because of allergy exposure. And one little tip here is patients with angioedema are more likely to report complete loss of voice and difficulty inhaling and exhaling, but ILO patients are less likely to present with complete loss of voice and less likely to present with that difficulty exhaling. It's mostly on the inhale. ILO can be considered on the continuum of irritable larynx syndrome with chronic throat clearing and chronic cough as milder forms and laryngospasm as the most severe form. As we know, the larynx is responsible for detecting and responding to irritants. So most patients with ILO will have what is described as a functional disorder of the larynx related to its role as the upper airway organ responsible for the protection of the lower airway. Again, that idea about the caveman status, it or the vocal folds think they're doing their job. This protective role is primarily executed through the laryngeal adductor reflex, known as the laryngeal chemoreflex, a brainstem-mediated reflex that prompts glottic closure in response to noxious stimuli. And again, we know this as very important for during the swallow, of course. The laryngeal chemoreflex can become hyperstimulated even when exposed to benign stimuli, and this can result in ILO. The mucosal lining of the larynx is among the most densely populated sensory receptor region in the body. And again, the highest density is usually along the laryngeal aspect of the epiglottis, the aryepiglottic folds, the arytenoid cartilages. Again, we know this because of swallowing. Commonly reported ILO triggers include allergens, odors, ambient temperature, humidity changes, and reflux. Commonly reported chronic cough-related triggers are exposure to smoke, reflux, postnasal drip, odors, fragrances, and ambient condition changes. However, people can have very unique triggers, so it's honestly not about what's a normal trigger, it's what is the trigger or triggers for the patient. And so that's where the case history and discussion comes in. You'd be surprised by some triggers that may be very unrelated to the common ones. So it's about meeting the patient, like always, where they're at and starting there. So CHS, again, this has been called several things, laryngeal hypersensitivity syndrome, irritable larynx syndrome, chronic cough, neurogenic cough, etc. But some believe this is an umbrella. And again, laryngospasm, EILO, ILO, cough, globus, throat clearing, MTD, MTDG, etc. are all kind of raindrops coming off of this umbrella. So whatever raindrop you see the patient for, what can you do? You will make a difference. And so just keep that in mind. Everything affects everything else, especially in this region. And even if we're just talking about voice, which we're not for this talk, but I always tell people we are not just vocal folds. We are not just a larynx walking around. We are a whole body. And again, this rings true for this idea as well. Patients are likely impacted by a variety of things: GI reflux, cardiac, sinonasal, hydration, laryngeal, medicated related things, pulmonary, neurogenic, psychosocial, etc. So it's important to address co-occurring things, and 40% of people do experience these co-occurring conditions when they have the cough hypersensitivity syndrome or, again, ILO, etc. So back to ILO, clinicians should be aware that many patients presenting for ILO can show evidence of co-occurring or mimicking conditions, especially BPD. So this often includes excessive chest expansion, paradoxical backward anterior abdominal wall displacement, recruitment of accessory muscles of the shoulder and neck, and backward tilt of the head during inhalation. But there's lots more on this later with BPD. Very quick video. I also showed this last time. This is an example of ILO during an exam. Let's see, hopefully it works. Yes.
Through your nose.
So this patient was breathing through her nose right here. And you can see that inward movement of everything when it should be fully opening. And she was making a stridorous sound. So during the exam, her chair was turned. We were watching in real time. And I got her to do a double sniff, followed by an E or a pursed lip exhale. We did a variety of different things. But she just kept watching herself have that control over her own airway. And she kept doing it. But she had had this condition over a year and had never had any visual feedback, biofeedback of what was going on. So she was very excited about her own power to control the issue. So typical breathing patterns versus ILO or ELO. And they both can be seen, and seeing is believing, especially when you're taking the patient through a biofeedback via an exam. It's very powerful. These are things to remember, to consider. So lots here, but remembering the mimics, the multidisciplinary team, importance, confirming ILO with laryngoscopy. Provocation is gold standard, so greater than 50% closure on inspiration is abnormal. However, this is not necessary to treat the symptoms, and it's always valuable to do trial therapy to see if symptoms improve as well, especially if their diagnosis lines up with upper airway. Provocation should aim to reproduce clinical features and ideally use the patient's known stimulus if they are aware of their own triggers. We'll get more into ELO provocation later, so I'll leave that one. ILO, throat tightness, throat, upper chest, region of tightness, rapid onset, specific triggers may be there. Breathlessness, worse on breathing in, odors can trigger attacks, breathing noisy during attacks. Exercise could be a trigger, especially for ELO. Outside of ELO, some patients experience clinical episodes without a trigger. Inspiratory stridor, absence of expiratory lower airway wheeze can be useful to diagnose the ILO. Suboptimal response to asthma treatments. PFTs can show a flattening of the inspiratory loop, but this is not always the case. So our power of the differential diagnosis and therapeutic strategies and trials can be very important. And ILO and asthma, again, can coexist. Case history, so important for all of these conditions. A suspected ILO patient serves 3 key objectives for this case history: establishing rapport and trust. Very important. Again, remember, this patient may be very frustrated and not have trust when they walk in the door just because they've already seen so many providers. Obtaining a comprehensive symptom profile and diagnostic history, differentiating ILO from co-occurring or mimicking conditions. And again, cited article, which is 37 here, but it's in my references. It's wonderful, and it has great graphics tables and Q&As, and also script examples of case histories. And I highly recommend checking it out. It was just published in Perspectives. So these are some great questions to ask, and you really want to take time talking of these details. It helps you to differentiate what's going on, and if there are multiple things going on. So when things started, describing the symptoms, describing what it feels like, describing the triggers if known, inhale or exhale or both. Is there a tightness in the throat or the chest or both? Does an inhaler help? Is resolution of the episode quick, or does it take longer to recover? Because this speaks to different things. Is there a sound associated? Can the patient mimic the sound? Especially when the scope is in, can we watch what that sound does on the inside? Does anything improve the symptoms? Has anyone ever visualized the larynx? And has the patient visualized their own larynx, which is really, really important? Baseline testing, as discussed, laryngoscopy, video stroboscopy, ruling out obstruction, ruling out a mobility impairment. I mentioned the case of a tennis player had ELO, and for some reason, the first visit, I didn't have access to the scope. I think our laryngologist was in that room. So I did a basic eval, spent a lot of time with her, etc. The next time I scoped, because she was an outside referral, she had a vocal fold paralysis. And so this certainly could explain her feelings of breathlessness and tightness in the airway, difficulty on the inhale, especially during exercise and tennis playing, etc. So then we moved that along for CT and to figure out more about the paralysis. So important to rule things out, of course, but then also use it for provocation testing, to visualize, to troubleshoot, to work through an event. And visualization without provocation is excellent too, because even while working through basic tasks, breathing techniques, even aerobic techniques, etc., it gives the patient feedback, confidence, understanding. And we'll talk about this later, but we can kind of fake an event. If we don't trigger one, we have the patient hold their breath or mimic the sound. We watch what happens, we help them see what happens, and then in real time, they work through it. And then again, gain confidence in their own ability to control these events. And then kind of trial all the exercises possible that are applicable because some could work more or better than others for the patient. Likely already completed, but important pulmonary, GI, cardiology, and CT related diagnostics. And again, we discussed some mimics, but some other ones: extrathoracic obstruction, BPD and DB, laryngeal edema, angioedema, anaphylaxis, laryngospasm, panic attack, respiratory laryngeal dystonia, exertional dysautonomia, and diaphragm flutter, mast cell activation syndrome, etc. So ILO diagnosis, the best way again is to complete the laryngoscopy when symptoms are present. That can be completed by anybody that's trained in doing so. Other breathing tests such as spirometry can be useful, but again, only if they're completed when the symptoms are present. Laryngoscopy changed the diagnosis in 67% of patients, which can lead to changes, which did lead to changes in treatment and biofeedback to the patients, which again, one of the benefits of scoping, so important. This is kind of my passion slide here. There's so much value in using the scope for biofeedback. I believe in this for airway, for voice, for all kinds of, for swallow, of course. This can be diagnostic and therapeutic. It's so important. It provides a visual for the patient in real time and or via the playback, guides them to work through the symptoms with proven techniques and watch their value and efficacy in real time or again via playback. It provides time to trial which techniques may work or even feel better than others. Because although we know they likely all work, that's why we're teaching them to the patient. Sometimes they connect to certain ones better than others. Sometimes they actually look different on the inside, depending how the patient is doing it, etc. So that visual can be very helpful. The patient doesn't need to create a trigger or episode. They don't need to experience a trigger episode. They can create one, as mentioned earlier, via negative practice, and they watch while they're working through it to overcome the episode. So laryngeal imaging, inspiratory vocal fold closure exceeding 50% has historically been used as a diagnostic criterion for ILO, and this was further confirmed more recently in 23. When patients are asymptomatic, laryngeal structure and function typically appear normal. Symmetric vocal fold abduction opening during inhale and adequate patency during exhale. And of note, and this is important to know, some degree of vocal fold adduction coming together, up to 25% during exhale, is a normal physiologic phenomenon. It helps prevent air from escaping too quickly. So don't judge on the exhale coming inward because that is normal, 25%-ish. So, three distinct types of supraglottic collapse have been identified: forward prolapse of the arytenoids, redundant interarytenoid mucosal prolapse, and epiglottic prolapse. The article mentioned earlier has great additional pictures for this as well. And related to EILO, supraglottic obstruction has also been observed in otherwise healthy athletes with no history of these complaints. So, again, something to keep in mind. So there are several cases, as mentioned earlier, of these conditions being misdiagnosed as asthma for long periods of time, even as long as 15 years. So this is our value in really discussing and parsing out the differences between things and therapeutic trials, etc., to really help the patient not go crazy thinking there's something wrong with them that isn't. So it's our job to really understand how to complete that differential diagnosis. And misdiagnosis, as mentioned earlier, can lead to morbidity, increased costs, misuse of measures of asthma control, etc. And we all know inhalers, especially when not needed, are not good at all for the larynx. They dry you out, they can irritate the tissues, they can lead to fungal laryngitis, etc. timely and accurate diagnosis of ILO and the use of breathing exercises have the potential to eliminate or minimize the burdens on the patient and the healthcare system. There is a great ILO-ELO asthma comparison chart also in the article mentioned. So patients can be prompted to recreate the sensation of throat tightness or the sound of their breathing difficulty. These are good questions to ask. Encouraging patients to mentally and physically engage with the sensation may facilitate real-time visualization of laryngeal obstruction. So that's something to guide them to during the scope or otherwise. Asking patients to demonstrate the sound they make when they experience the difficulty can be helpful in determining the presence of inspiratory stridor versus expiratory wheeze. If patients are unable to demonstrate, SLPs can model that, and the patient can decide which noise best demonstrates their issue. Patients can also report a variety of accompanying symptoms, as mentioned: cough, voice changes, chest tightness, chest pain, feelings of anxiety, tachycardia, dizziness, syncope, and paresthesia, or tingling sensations. But if the patient's history strongly suggests ILO, this can serve as an opportunity for diagnostic therapy. As mentioned earlier, a short-term trial therapy focused on laryngeal control strategies applied to relevant triggers or activities with observed symptom improvement can provide supportive evidence for ILO diagnosis if it's not obvious yet. These are common patient-reported outcome measures: the dyspnea index. Some use the vocal cord dysfunction questionnaire or the PVFM questionnaire. We'll talk about others as well. Of these, I more often use the dyspnea index. How to diagnose ILO during sleep. So there's something called DICE, drug-induced sleep endoscopy. I won't go deep into it, but it's pretty interesting stuff, and it is a way that we can really find out if it's going on during sleep. This was covered at one of the upper and lower airway conferences I was at. I think this one was more discussed at UPMC. ILO and ELO treatment. Speech-language pathology management of ILO and ELO typically involves educating patients about the condition, promoting lower abdominal breathing patterns, identifying symptom triggers, training body awareness and awareness of those triggers and those sensations that are related, teaching recovery techniques to relieve dyspnea, and providing opportunities to practice and apply these strategies in real life contexts. So lots going on here, but those are pretty much all of our goals in this treatment. Airway-related therapy with the SLP is the cornerstone of treatment of ILO, and to be honest, ELO as well, and BPD, DB. It's important that we also manage co-occurring conditions that can irritate the larynx, as mentioned earlier as well. 95% of patients treated with therapy are able to control their symptoms. 3 to 4 sessions with a trained SLP are usually required for a patient to feel confident in the techniques, which must be practiced during asymptomatic periods to ensure success during attacks. However, often a fewer number of sessions could also be effective. I do want to mention, I didn't add another slide because there's so many anyways, but there is kind of recent research that I know Claudio Milstein looked into with patients long term, and it kind of showed that people still use the techniques year and a half out. So it is a sign that although the techniques help and we help relieve their symptoms, etc., they are still using them. So are we really fully curing them or helping them 100% manage the condition? That's when the thought towards this unified airway idea comes in, because maybe it's not just upper airway, maybe it's also BPD, DB involvement, and there should be a holistic approach involved always. So keeping that in mind, SLP intervention for ILO demonstrates good outcomes across both pediatric and adult populations. And more specific benefits include improved tolerance for physical activity, decreased reliance on inhalers, sustained use of therapeutic strategies over time, objectively visualized reductions in glottic obstruction during continuous laryngoscopy during exercise, which is what CLE is, or other laryngoscopy-related findings. So behavioral treatment for ILO, education, including scope with biofeedback ideally, normal versus abnormal education, anatomy and function, ways to improve the laryngeal environment, and awareness of triggers, sensory observations, the importance of substituting more optimal motor patterns. responding immediately upon recognition of the first sensation, hopefully prior to ILO occurring, to reroute and maintain prior to an actual episode, immediately in the presence of possible triggers, even before actual sensation occurs, prior to any sensations or events, and to reroute and maintain control. And if and when within an event or episode already occurring, responding immediately with friction-based exhale and reroute, maintaining at least 10 cycles or however much is necessary to reroute the episode. So behavioral treatment, again, there's so much here, and I will go kind of quick because we have a lot to cover, but ideally, you're doing recovery breathing techniques. This could involve sniff plus pursed lips, sniff plus sniff plus SH, sniff plus straw exhales, and that would be with a very skinny, ideally, coffee stirrer straw. This is going to provide more back pressure, which actually is better, and it also gives the patient a way to direct. I have a lot of people that use these for cough hypersensitivity syndrome. Then we have purse slip in, purse slip out. This is more for smell related triggers because if the patient has a smell trigger or scent, we don't really want to encourage a sniff, right? Because they're going to smell it more. That's a great time to use the purse slip in, purse slip out. Now, options to double or triple inhale. You might remember the video I showed you a second ago. That patient liked the double inhale, and that sometimes makes people feel like they're just getting more air because they're doing a double sniff. You can pulse the exhales to maintain the focus and friction. I think this is really helpful, especially again in cough, but also in airway conditions. If they can't maintain the focus to prolong an exhale, because they might be irritable or they would feel it occurring. So that would be more like, let's say I'm using an S. They're trying, but it's irritable or this is wanting to occur. So by pulsing, they keep the focus and they find that friction, they feel the sensation, and they stay in control and they'll go and they keep doing those pulsed exhales until they feel more in control, and then they can alter it to the prolonged exhales. There's value, so much value in starting with the exhale and feeling the friction. So the purpose of starting with the exhale, and again, this is for recovery for cough or breathing, ILO episodes, is that if you're feeling this irritability, or the patient is, whether it's the airway closing or a sensation of irritable larynx, sometimes it's really hard in that moment, especially airway, if you're feeling this, to actually sniff because it's tight here. So the important thing is we need to let go of what's being held. So that's why we say instead of starting with a sniff, start with a friction-based exhale. They feel it, it gives them something to direct up and out. You let go of what could be held. And then you start with the cycles. So there's a lot of value of starting with that friction-based exhale. And the value of friction too, if I didn't mention, just like a semi-occluded vocal tract exercise, we are creating a smaller opening. We're feeling it. We're giving ourselves something to feel, but it's creating a back pressure that actually opens the airway, opens the throat, and that's a really, really good thing. So lots of benefits of doing these techniques, even within the anatomy, more than we even would guess with just opening the vocal folds. Stay tuned for more in Alobi, and this is management for EILO, one management for respiratory retraining in general for BPD/DB, but it's still helpful, as mentioned earlier. Pattern training, full body breathing, 360 breathing, nasal focused breathing, etc. I don't know if anybody has one of these retractable balls, but I love to keep one in my office because it really is a good visual for optimal breathing patterns for patients. So I often will get that down from the top and use it in clinic. And also, very important, awareness of breath holding tendencies and what to do next to reset. And again, starting with that exhale is very important. But noticing is first step. During the scope with biofeedback, this increases, again, the self-efficacy, doing all these techniques with the scope. I do them all the time. And even if I don't have time on the first visit, I will often bring in a scope and use this therapeutically to gain the patient's confidence, to improve the patient's confidence in specific techniques or just in doing this so they can watch their own anatomy. All right, so recovery breathing again, if the patient feels the tightness, fill in the blank sensation, or even before the patient thinks they might feel it, then they want to start this exact thing, which is kind of what I described. This is an example of a weird trigger. I had a patient whose trigger was elevators for ILO. And again, that's kind of strange, but it could have to do with maybe a little anxiety about elevators or going to work. She had to take one every day or who knows. But we established that, and then while she was driving, she was doing the techniques. While she was walking into the office, doing the techniques, as she was pressing the button of the elevator, doing the techniques, same thing, standing on the elevator, doing the techniques, and eventually getting off, etc., and worked through it. Eventually didn't need the techniques because she overcame that. But again, awareness, and she knew right when it was going to occur for her. So just an example. Asking the patient to focus on that soft S sound again has a dual effect of diverting attention to that, but also giving that back pressure. Panting and coughing have been found to be helpful in acute attacks based on this research. It's the most practical on-site maneuver to abort an attack and activates the PCA muscle. But again, looking with the scope and seeing what works for the patient. To be honest, I use the recovery breathing more than panting. They all work very well. So, laryngeal control therapy for irritant-induced ILO. Physiologic target, reestablish laryngeal patency in response to irritants and encourage implementation at the first warning sign. That's really important that you alert the patient to their warning signs or you help them become aware of the breathing difficulty or proactively before exposure to the known irritants. Relax throat breathing. Releasing tension in the jaw, lips, tongue, shoulders, guiding them to inhale nasally with the tongue resting gently on the floor of the mouth and lips closed. Again, based on this research, a lot of times I prefer a tongue posture that's against the roof of the mouth. Emphasize low rib cage expansion and abdominal distension during inhalation, followed by a passive exhale on the prolonged, unforced S, friction based. Another option, the deep nasal sniff with pursed lip exhales. Again, we've kind of gone through this idea. This is just from another study, more recent, diverting attention away from the larynx and focusing on subtle abdominal engagement during this exhale. So you don't want them to be consumed with that yet. We're focused on managing this, but subtle awareness and engagement is good. And they can use FSSH. I really find the more friction is helpful if the attack is really bad or if they want to achieve even bigger of an opening. The more friction creates greater back pressure and opens more, but they all do. More friction can also provide them something to feel even more so and redirect. But bringing their attention to whatever it is, and maybe it needs to start with more friction, but it can evolve in their cycles. I usually say 10 is a good number, especially the practice, to be less friction based and even more discreet, like the pursed lips. Straw sit method of inhalation. This is kind of that pursed lip in, pursed lip out. Definitely, I use this during scent based triggers. And visual biofeedback, as discussed earlier, using that scope to help, especially if you have access to one, of course, and provoking, triggering an attack, yes, but also kind of faking it using negative practice. Give them options, give them time. They probably have more time with you than with physicians. So let this be a learning tool for them. It's amazing how much confidence they gain by watching their own anatomy. And they really see that as a partnership between you and them because maybe you're the one that's allowed them to see their own power, not only feel it, but watch it. There's a lot of power in that. So the consistency of practice is so important. I usually recommend 10 cycles of this breathing or whatever technique we're doing every hour throughout the day. Sounds crazy, and I always say that, but it should take you 1 or 2 minutes. And again, it's not for life, it's for now. It's excellent for motor learning, and it makes the patient a pro. It gives them the confidence, so when they are in an attack, they know right what to do. It's also a great way to reset the breathing every hour and calm the larynx. It's a great reset tool in general, and it's great to practice in the presence of the trigger as well. This is a side note, but if the trigger is a scent, we don't want to bring that into the therapy room and just spray, spray, spray and say, let's work through it. You go outside the therapy room, spray the scent on a tissue, and then bring the tissue in. Maybe you need to put the tissue in a jar, keep the jar closed, bring it in, uncover a little, work through. It all depends on the severity, but that's a good idea so that it's not overwhelming or a negative experience. So, as we know, the purpose of this treatment is to reverse and prevent the symptoms, optimize the glottic opening, and meter the respiratory rate. Body scans are great. Teaching the patient even things like CTT, getting them out of their throat. Awareness is huge. Noticing, again, that full body breathing. The more we can bring the attention out of the throat, the better. A good question to ask is not is it perfect, but does it feel better, worse, or the same? And keep adjusting what you're doing based on that. Again, giving the patient power to decide and know what to do next. And then mindfulness, of course, and grounding are really great as well. And those are some examples of things to do, which again, we'll get into a little bit later. Related to irritant desensitization training, some things to remember. You want to start with even just salt. Bring it in. Start doing the techniques with salt present. There's no smell. Practice the techniques. Get good. And then, like I said, slowly introduce even with small ways, like spraying on a tissue, bringing the tissue in, or having the jar there closed and barely uncovering it, seeing the patient's reaction as you continue to work through. Also, the patients with these conditions often are also hypersensitive and or anxious about these conditions as expected and as would be normal, right? Because this involves breathing and a control over the larynx. So asking them, hey, what is normal actually, right? Have you noticed gravity today? I got this from I believe it was Juliana Litz at the Airway Conference in Colorado in Denver. But I love this idea because it's it's something none of us notice, gravity, right? We're always just standing on the ground walking. We're thankful for it, but we don't notice it. So just kind of bringing the patient's attention. Okay, what is normal? What is your normal? How can we find it? What'll help you the most? I love this too. There is a less defensive pattern in exhalation. So you can change the protective pattern by, again, starting with that exhale first. Can you extend the time between sensory and motor response? Get familiar with the sensory feelings. There is behavioral change available to you, patient, as soon as possible. Side note, ILO-ELO specific treatment may not lead to complete resolution of symptoms, and patients often gain additional improvement, as discussed, with the management of DB and BPD, posture, body tension, manual work, and even psychological and cognitive components as well. So, training that strengthens inspiratory muscles also has been proven to improve vocal fold abduction during inspiration by increasing inspiratory and expiratory pressures. This applies to ILO, ELO, and BPD DB. And more than like EMST and strength training, in these patients, at least at the beginning, we do want to focus more on pattern training, which would be a little more like the power lung, power breathe, the breather voice, the breather fit, etc., just to breathe into resistance. Or again, we'll discuss later, but using the hands, using a resistance band like you would use in Pilates or other kind of classes, but then putting that around the waist and breathing into it. There's lots of ways that we can train that. Probably for sake of time, I'm going to skip this part, but I loved it. And it was a talk that Jackie Gunner Schmidt gave at the UPMC conference on airway. And it's just the idea that if we could change the perceptions of the patient's evil vocal folds, villain to victor, because again, it's a protection. So is it really a disorder? And just kind of bringing attention to these ideas is very helpful for the patients. I wish I could chat more about it, but for the sake of time, I'm going to skip this part. But it's really important to change that narrative. And a normal physiologic reaction is to protect. And if they can control it, and it's important we start in the mind and their education and understanding of this first. So, mental skills as related to treatment. These are things to keep in mind. These are very important because remember, breathing and or lack thereof or lack of the ability to control it can certainly bring on anxiety or some of these feelings. So it's important to also be aware of these things and how within our scope of practice we can address this also in therapy. And so again, this is just taking a second look, but using biofeedback as discussed, it's the same video, so I won't show, but again, the patient's chair was turned. We discuss, we're working through techniques during the exam. So laryngospasm, I couldn't not mention this because it is kind of more the other end of the spectrum, but just so you know, it's a condition, as I'm sure you all do, where the vocal folds suddenly spasm involuntarily and they shut. And it's usually a longer shut than something like ILO. Sometimes people can pass out. This can also cause stridor. It's an immediate onset of inability to breathe in or out. And sometimes people have this as related to needles being scoped. So it's important to be aware of this. We all know if we get too close to the vocal folds or go under them, if their sensory function is intact, we can trigger one of these. So it's really good to be aware. Patients can often be frightened by this. One thing to keep in mind is to help them remember we all can actually hold our breath. So if we ever swim underwater or we even just time ourselves, hey, hold your breath. Even just this simple fact will give them more confidence that they can live through a laryngospasm. And as humorous as it sounds, because it's not helpful to say, stay calm, but it does help in laryngospasm for things to relax and then restart the breathing. So, side notes there. This is another interesting concept from one of the airway conferences, but we talk about MTD for voice, MTDG as related to swallowing. MTD dyspnea is SOB driven by the inefficient coordination of muscle systems. Airway complaints get worse with talking, but there are no voice complaints. Just an idea, kind of food for thought, but I think it's pretty interesting. And I do see this in a lot of patients. So the whole system is always connected. It's something important to think about. So now we get into ELO. So this is ILO, but the trigger is exercise. So as discussed, ILO triggered by exercise. The perception of airflow obstruction is again at the level of the larynx, and this is ideally diagnosed with CLE, continuous laryngoscopy during exercise. This is not available at all places, centers, etc., but there are definitely some places that do it. Most commonly National Jewish, UPMC. There's certainly some places in Europe as well. But this is really good because during exercise, usually a treadmill or a bike, the patient has a helmet and a scope, and we are capturing the spasms, the conditions, the supraglottic collapse, whatever it is during exercise. This is more common in females, and O2 sats do remain stable. So laryngeal narrowing, I think this is interesting. Under such conditions, exercise may initially serve as an adaptive function. Similar to the pursed-lip breathing, reduces airway resistance, prevents dynamic collapse, etc., because of that back pressure. However, excessive narrowing that impairs airflow and causes dyspnea or exercise intolerance represents a maladaptive response, likely triggered when an individual surpasses the adaptive limits of the pulmonary system. So again, the larynx, primarily tasked with protecting the airway from aspiration, defaults to protective closure under stress. And again, sometimes high intense exercise equates to stress in the eyes of the body, or if the pulmonary system isn't as conditioned as it wants to be. So just an idea here. This is also when DB and BPD related treatment also comes in more holistically. The term wheeze is often used to describe the distressing sound that co-occurs with this dyspnea during surrounding exertion. So all sounds will close the larynx and stop airflow. It's not constructive for easy breathing. Prototypical ELO symptom is inspiratory limitation, inability to get enough air in during exercise. And most often this occurs at high intensity exercise and resolves within a few minutes when the exercise stops. 35% prevalence in athletes. And I think this is cool. I mean, not really if it's the athlete, but the International Olympic Committee now recognizes ELO as a significant contributor to breathing problems in physical activity. Cross-country skiers and biathletes have a very high prevalence of asthma and ELO, which is believed to result from repeated and prolonged inhalation of cold, dry air, leading to osmotic changes and epithelial damage in the airways. So environment matters, of course. Patients can feel suddenly out of shape, heavy legs, arms, slow recovery, air hunger, difficulty breathing in during exercise, and asthma meds are not working as expected. So 56% of other conditions are often overlooked if we're only considering asthma, but 25% of patients with ELO also have asthma. So again, our job and others, but of course we can play a role in ensuring it's not misdiagnosed for asthma. However, and again, refer to the ILO section, what we already discussed. of patients with ELO, common co-occurring diagnoses, as we know, asthma, allergies, BPD, and anxiety. Reflux is actually less common co-occurring condition based on these studies. Examine, test, treat, and examine again. I remember Dr. Todd Olin saying that at the Denver conference. Really, really important. If you're not getting what you think, examine again. Keep looking, because if there's something to catch, most likely you will, especially if you have access to CLE. If you can't elicit 100% exercise, you probably won't see much. I remember him saying that as well. It's really important. And again, so CLE is ideal for this. If you're not able to access CLE, coach the patient through heavy breathing with the scope in to identify redundant mucosa. However, the static resting hyperpnea is a different part of the curve and it might not provoke the symptoms. So you need to match the sport as close to the real life situation as that is ideal. And studies show outdoor exertion, likely again environmental, is more likely to induce symptoms than indoor. And Denmark and Norway now have formal diagnosis codes, so I hope we do at some point for ELO. CLE versus CLP. So just keep in mind, CLE is this idea of continuous laryngoscopy during exercise. CLP, continuous laryngoscopy with provocation. So more related to the sensory-based triggers of ILO, etc. As discussed in the CLE score system, the MAT grade of equal or greater than 2, equal to or greater than 2 is abnormal. That's a rating scale if you're catching these episodes during CLE. Interestingly, the research shows it's not exactly a valid or reliable kind of scale, but at least it's a way to quantify based on what you're watching. For the sake of time, I'm going to skip this, and I did show it in the last talk, but I think these airway conferences were just so incredible. I got to attend the one in Denver, and there is some great video here from CLE. This is the one in Pittsburgh, and I'll just briefly show it in case you didn't see it in the last talk. Supraglottic compression during, this is just a walk, but she gets to more jogging and running. And this is CLE, an example of.
It's interesting because it's early.
Yeah.
Right?
And she's barely running, and we're starting to see this, right?
But how some patients that get this before that.
And now then this is continuous bronchoscopy during exercise, which is wild because again, the scope is past the vocal folds into the airway, but this is important to catch something called EDAC, excessive dynamic airway collapse, which we'll mention briefly. Physician in the UK is the only one I know that does this.
I'm straight to the back and I say, well, try having it in a trachea.
And what he just said was, some people say it's horrible to have the scope in while you're running, but try having one actually in your trachea for that bronchoscopy. But again, these are the ways we capture these spasm/attacks. Also remembering we don't have to do that, especially if we don't have access. We can treat based on the history, the symptoms, and do trial therapies to see. So hypothesized causes of ELO, these are ideas, smaller airway dimensions, so could be why there's a higher percentage in adolescent girls, possible defects in structural integrity of the supraglottic structures, lacks connective tissue, even connective tissue disorders, overreactive glottic closure reflex, increase in demand for ventilation due to this increase in physical activity and demands. Again, sports, that's when this starts. So that's why a lot of times kids or teens that are younger are always diagnosed with this exercise-induced asthma, but maybe it's the first time they're really increasing this demand for exercise and they're noticing these feelings. And then again, there's some risk factors, of course, but again, ELO versus everything else. So lots of things that could be going on. Don't always assume these conditions. Keep digging. And it's important to have imaging as you need as well. History is so important, as we discussed with ILO, but there's even more important things to ask with ELO. And an example of some of these, where do you feel it? Is there difficulty moving the air? Is there wheezing? What does it sound like? Can you imitate it? Do you have a recording? A good thing is to ask the parents or the child, teen, adult to bring in a video of themselves exercising so you can really see what's going on. How long does it last? Is there other shortness of breath or body feelings? dysphonia, chest pain, cough, throat clearing, changes in weight, during what type of exercise, is it after a certain amount of time, how long does it last, what mile marker is it at, if it's like cross country, how do you recover, do inhalers help, all those things. Important, of course, to rule out neurologic etiology and discern if ILO or EILO is occurring in isolation or if there are any lovely mimics going on. This certainly influences treatment planning. And both adults and children with co-occurring upper airway disorders can learn to distinguish the difference between symptoms of the competing disorders. So we can learn, but we can also teach the patients to learn the differences in the symptoms. So if someone has asthma and ILO or EILO, they would know what feeling would get a benefit from an inhaler and what feeling would likely not. There's a really great differential diagnosis in this article by Sandage et al., and there's an example of that here. These are examples of proms for EILO, and the Elodie is a great prom for exactly what's going on here, EILO, and it was created by the group at National Jewish as well, but you can certainly use the ones as mentioned before. Treatment for EILO. Behavioral intervention is the foundation, similar to ILO, but there's a specific focus on exercise-related breathing and Elobie techniques. Most adolescents with EILO actually treat themselves by stopping activity or being less active, and that's never our goal for them. We want to help them where they're at and to work through this. Common response from doctors would be inhalers, 262 million people. And we do know their effect on the vocal folds and on the larynx with irritation and dryness. So we want to know, do they really need that? What's going on, right? Behavioral treatment for EILO could be kind of lower intensity and higher intensity ideas. Higher intensity, certainly the Elobie techniques. And we don't want to forget the asynchrony, which would allude to components of DB and BPD. And looking at posture, trying to have the patient breathe in and out in different positions, guiding them to understand, do they feel the difference depending on the position or the posture? That can be a really valuable tool as well. Many laryngeal control techniques, as discussed in ILO, are recommended to be used at the first sign of breathing difficulty and can be discontinued once symptoms resolve. So EILO basic inspiration or Elobie techniques and pace breathing are exceptions. Those can be helpful throughout the entire exercise, although they require practice to avoid disruption in performance. So it takes a lot of consistent practice. But when we get to that, I'll also mention sometimes we use the technique as needed as well. Start training these strategies at lower exertion levels, gradually increase intensity to build skill and confidence. And again, of course, use the scope, because I do that with Elobie as well. It really helps the patient see that biphasic inhale, providing two openings. This, in a nutshell, is Elobie. And again, crediting all the wonderful people at National Jewish for creating this, the Olin team. But Elobie stands for exercise-induced laryngeal obstruction, biphasic inhalation, two-part inhale. There are 7 steps broken down. And broken down, step 1 is planning. This should be done every 4th breath, although again, this can be changed based on the patient needs. Step 2, emptying. It's a deliberate exhalation of all air to prevent subsequent breath stacking, and that's the presence of a full thorax, which leads to uncomfortable and ineffective breathing in general. So the empty breath is on breath 3, prior to the biphasic breath on number 4. And so here we go. Step 3 is the splitting, and that's that biphasic breath, the 2-part inhale, and it's high to low inspiratory resistance. And again, for good reason. Remember that back pressure idea. So one example is the tooth variant. There's also a lip variant and a tongue variant. We choose these based on the patient, their sport, if they have a mouth guard, what they like, etc. But high resistance is 1/3. And in the tooth variant, the teeth are pressed firmly against the lower lip, and the high resistance through the teeth, also called squeaky teeth. And the low resistance is 2/3, so a little bit longer. The jaw and the lower lip drop away from the upper teeth, which allows the air to flow freely through the mouth. And this could be called the Vader breath. Drop the jaw and really get that nice air coming in all the way to the lungs. The lip variant, similar, but that instead of the squeaky teeth, it's going to be like you're sucking through a very, very thick milkshake. You want to feel it, you want to hear it. And then into the 2/3 part low resistance Vader breath. And then the tongue one, to be honest, is done, I feel like, less often, but people will do it sometimes if there's a mouth guard issue. But the tongue is against the roof of the mouth, and the patient inhales through the nose, and then that's the 1/3, and then the 2/3, they open the mouth for the Vader breath. Step 4 is timing. Again, already discussed kind of in step 3, but it's high resistance. The high resistance phase must be shorter than the low resistance. Tooth or lip variant, again, 1/3 of the biphasic inhale, open mouth Vader breath, 2/3. Step 5, forcefulness. Some degree of forceful is normal. Again, not here, but in the body and in the condition, in the posture that is chosen. It needs to be purposeful, almost like popping off a cap. It's a forceful thing, but not effortful force in the throat. Step 6, fullness, primary form of sensory biofeedback. When you feel fullness of the breath, it's fullness of the whole breath and in the body, and especially with step 7, which is ribs, consciously attempting to force lateral side portion of the lateral ribs inward during the emptying phase, so breath 3, and then outward during posteriorly and backward, outward and backward with the biphasic inhale. So awareness of, again, the body, so important to get out of the throat. I usually tell people this is complex, takes time to get used to. Perfection is not expected, but what we want them to learn, especially on day 1, is the 2-part inhale. And planning and practicing, especially, we don't complete this biphasic inhale every breath because that will get us to hyperventilation, which we certainly don't want with these people. So it's why it's every 4th breath. And then again, practicing at rest, practicing seated, practicing on a treadmill or stationary bike, practicing in the sport, going outside, running. I do it all the time with people at the clinic. It's wonderful because it gives you a little break in your day, but you really help the patient. If it's football, we've ran drills before, depending on the play. There's lots you can do with it. And if you don't have access to a pool, obviously it's wonderful if you can to help the swimmers. But if you don't, you can still kind of walk the patient through the motions. I've even went so far as having a stool that rolls. So we went through a long hallway or outside on the stomach, and we did all the strokes with a technique. So, I mean, you can get creative, but it's all about taking this to real life and progressing as needed. This is a really great visual from National Jewish about the planning, the emptying, and that biphasic inhale. So in a nutshell, again, we're guiding the patient to take 3 normal breaths, focused on the relaxed, natural inhale and exhale, how they breathe when they exercise. At the end of the 3rd exhale, we instruct them to fully empty their lungs. And on the 4th breath, they do the biphasic inhale. There's 3 variants as mentioned: lip, tooth, and tongue. And there's a lot of troubleshooting and teaching and customizing involved in this training. We might slow the rate of breath to match the cadence. Breathing will increase with pace. If the patient is a sprinter, we want to do at least 1 biphasic inhale during the sprint, and then maybe continuing at every 4th breath during recovery. Changing motor plan, creating new neural pathways. We can get rid of this pattern. We don't want to empty completely, fully till there's nothing left because that can cause tension. But essentially on the 3rd empty breath, you're letting go of most everything. Negative practice is great here, so is a mirror to make sure there's not a lot of extra laryngeal tension going on. You can use the Borg dyspnea scale. Is this the problem? Or are you just short of breath because this is a really hard thing and maybe we need to up the conditioning? So kind of discussing that as well. Auditory and tactile feedback is excellent with the resistance training. The ribs, using mirrors, therabands, hands, the Buteyko belt, visuals like the retractable ball. Sprinters, like I mentioned, you want to do at least 1 split breath in a sprint and then move to doing it on recovery. Oral drive versus respiratory drive. So using the diaphragm and ribs to pull air in versus oral drive to really kiss and squeeze, because that might redirect the focus. Conditioning, repetition, high volume, skill acquisition, and retention ability to complete a high intensity without much mental thought, ideally, but there can be a lot to it. We can modify as needed for specific sports. This is when I love it, and I tell the patient this too, because they get overwhelmed by thinking, oh, every 4th breath and do this and do that. And again, the routine and the repetition helps. But if you're playing a game, what was told to me when I was trained in this, which I think is very helpful and I teach patients, is we do want to maybe consider, if this is overwhelming and the patient doesn't have yet, but we need a tool to start using immediately, to have them identify the exertion. So let's just say in basketball, could be when shooting a basket. The exertion is a great time to do the empty breath. So breath 3. And as they pivot, they will do the biphasic inhale. That is a great way to work this in as needed. Is again, identify the exertion, that will be the empty breath, and then fit in that biphasic inhale right afterwards. Do the technique if and when the patient thinks it might happen. That's another way to work it in. Or if it hasn't happened in a while, they can also do that. And again, supportive teammates and coaches are very helpful. But as we know, the goal is to prevent the breathing problem completely. The patients start the breathing recovery techniques before the obstruction occurs to bypass the attack. In a perfect world, they're continuing to do it throughout, but knowing that there is freedom in that as well. This is a great way to look at different sports and what to consider based on the sport. Again, from National Jewish. The physiologic target of laryngeal control therapy for EILO is to reestablish that laryngeal patency during exercise, as we know. Again, options. We know we talked about the Alobi techniques. Again, that idea of popping the seal, that's what forceful means in a good way. But then we can also do relaxed throat breathing, deep nasal sniff with pursed lip exhales, the straw sit method of inhale as well. So similar to ILO, and this may be all the patient needs. Again, high intensity, we want Alobi, but maybe slightly lower intensity, or if for some reason they don't want Alobi, this could be another option. The ventilatory demands of high-level physical exertion may not be conducive to exhale through tightly pursed lips or nasal inhales. Athletes could need to adjust the degree of the oral opening in that case. We can also try paced metered or ratio breathing, guiding the patient to develop rhythmic breathing with continuous airflow, avoiding breath holding, very, very important, aiming for 4 to 5 walking steps during inhale, 2 to 3 steps 4 to 5 walking steps during exhale, 2 to 3 steps during inhale, increasing intensity as able, adjusting as needed, whatever is helpful for the sport or the patient. And again, another hallmark, the visual biofeedback. Again, if you truly want to capture the spasm, CLE is necessary, but we can use scopes for biofeedback whenever. And again, very helpful for the patients. Now, this is, again, newer research, something I'm very interested in. I'm not yet trained in this, but I hope to be soon. There's something called the PI method, created by Sharon Frank, and this article from the Perspectives group that just came out in December 25 kind of alludes to it, describes it, but it's a holistic speech pathology treatment to manage the physical, intellectual, and emotional PI aspects of EILO. So there are some outcome measures that were used in the study. And prior to the treatment, all participants reported breathing symptoms. Following the treatment, significant improvements were evident on all 3 measures, and no significant changes were noted in the subgroups. So it's hopeful that this is another idea. EILO takes physical, psychological, and emotional tolls on the patient and their family, which can support the need for a holistic approach to treating this disorder by addressing the whole person and taking into account the importance of the body-mind connection. A patient's emotional condition can impact breathing and the sensitivity to shortness of breath, which can exacerbate the dyspnea symptoms and the extent of these symptoms. Since a holistic intervention approach often addresses psychological reactions to physical conditions, it's part of our scope through ASHA as SLPs to address the emotional reactions to the disorders that we treat. And that is cited also in that study. So the holistic mindset optimizes oxygenation through the body by reducing dysfunctional breathing and addresses the physical component via manual therapy and normalizing the breathing pattern, the intellectual component, focusing on increasing breathing awareness, sensing the body's positive change to better breathing habits, and the emotional component as well. So again, things to consider and always remember related to management of EILO, medical therapy, SLP, laryngology, Botox, behavioral health, social, and mental skills. And at the Denver conference, I met Erica Westhoff. She's a wonderful sports psychologist, and she sees EILO patients and trains them on mental skills and management of EILO in that context. So if you need a great referral for these athletes, I would highly recommend her. She has a great website as well. Kind of covers these things within the context of mental skills training for these athletes. There's also an EILO peer support group through Erica, and there's a Bergen ILO support group as well. And I've seen that there's another group on SIG 3. I forget the name right now, but I hope to be involved with that in the future. So more tips and tricks for a lobby. You can adapt therapy for the sports, even as simple as if it's a dancer, you can incorporate the routine, the facials in the routine with the Alobi techniques, and it won't be that weird. Same with synchronized swimming. Put it in the routine so the cognitive load is lower. Hockey, again, nose-based variants, so the tongue variant, if you're doing a Alobi, because of the mouth guard, or whatever sport has a mouth guard that is not conducive to the other techniques. We know therapeutic laryngoscopy, simulate the sport setting, use the breathing technique as actually doing the sport, considering doing the exercises and training in other sport-related settings too. If the patient only has the issues in one sport that maybe they do, and who knows if there's also an anxiety component or something too, because they need to perform high at that sport. How about you ask them to incorporate it when they play kickball for fun, and then they can practice and gain confidence too. And this will calm the system, which is important. Exhaling during strength portion, inhaling during the opposite portion. So even as simple as like a bicep curl, the exertion is the curl, you get deeper in the muscle contraction, and then the extension is more the part to inhale. So even keeping things like that in mind, training low abdominal breathing could be contraindicated for athletes of certain sports. Example, swimmers. They're often coached to maintain a straight spine with limited chest movement during inhales and tight abdominal muscles to minimize drag. And so again, for this, being aware of what you're recommending and what that sport is, and that is kind of based in this research study as well. But for your students or any athletes at all, promoting open communication between you, to the coaches, to the family, teammates, and with permission, offering yourself as a resource. Always asking what's going well. It's easy for anybody with a breathing condition to focus on the worry and the big concern, and then that can exacerbate the issue. So what's going well? I like the idea again with Dr. Olin, but the 91 and 9, can you identify the 91 things you could be doing right and not the 9 you could be doing wrong, right? That can be very common in perfectionistic type A personalities, which could be a lot of high-level achieving athletes, right? So keeping this in mind, EILO surgical suggestions, considerations, the last option. So again, this could be certainly with a arytenoid prolapse, redundant interrytenoid mucosa, epiglottic retraction. And so knowing you either are with a laryngologist or you know one to refer to that could manage things like this, of the supraglottic obstruction, when you know therapy is not the only fix, or maybe even, less than a portion of the fix, because there is something anatomical we need to help. GLO is the global initiative for ILO, and it was established at the Denver conference, and you can sign up to be a member if you're interested. And just briefly, like I mentioned earlier, EDAC, it's a pathological collapse of the narrowing of the airway lumen by 50% or more. And this is usually only found with bronchoscopy. And again, bronchoscopy during exercise if we really want to see it. Tips and tricks, again, even with regular scoping, but tilting the head down and turning to the side to view the trachea. Again, we really only notice this during exercise. I doubt anybody's doing continuous bronchoscopy during exercise. I only heard of it from that amazing physician. I can't remember his name right now, but he's in the UK. But that will show you EDAC. But to notice a loud monophonic expiratory wheeze, but similar time course as EILO with recovery, is a good indicator of this condition. So differential diagnoses, again, ILO, EILO versus asthma, and the Sandage article has a lot more to that as well, and the Tabor article. So lastly, breathing pattern disorder, dysfunctional breathing. Functional breathing disorders, currently termed breathing pattern disorders and dysfunctional breathing, are conditions that produce both respiratory and non-respiratory symptoms that are often resistant to the usual treatment. These disorders can occur alongside functional voice disorders, affecting both upper and lower respiratory systems simultaneously, and can be part of a broader pattern of body system dysregulation. So although these terms are often used interchangeably, DB is a broader concept, as mentioned earlier, encompassing multidimensional aspects of breathing dysregulation contributing to symptoms. In contrast, BPD emphasizes abnormal breathing patterns and was originally introduced in the scientific literature in connection with breathing disorders linked to movement and posture. However, again, people do use these interchangeably. And I feel like more trained BPD, but I'll use them interchangeably as well. And I do think DB a little more global. Research suggests management guidelines for difficult to treat patients with dyspnea should include recognition and treatment of DB alongside ILO, ELO for improved outcomes, as mentioned earlier as well. So in a nutshell, this is an alteration of normal biomechanical patterns of breathing in the absence of a pulmonary disorder, but lacking the laryngeal component. So inefficient breathing patterns, it's an umbrella term again, and we're likely going to see hyperventilation, periodic deep sighing, thoracic dominant breathing, asynchronous breathing, breath holding, air hunger, can't get enough air in, difficulty catching the breath, etc. Over bracing, air hunger is a common symptom, hyperfunction. Symptoms can be similar to ILO, ELO, and remember they can occur together. The clinical presentation does lack the laryngeal component. Sighing, yawning, breath holding, tingling, anxiety, these are all pretty common. And there's so much value as we progress to mechanical inefficiencies of BPD leading to insufficient gas exchange, chemical changes in the acid-base balance, reflecting changes in the metabolism of breathing, all that stuff. There's so much value in Buteyko method, which I'm trained in and I really love. So I highly recommend looking into that if you are unaware. But Buteyko really addresses breathing as a whole, nasal breathing, and the chemical components that are going on. Hyperventilation syndrome, it's defined as breathing in excess of metabolic requirements leading to a depletion of CO2 levels. This can occur as chronic, intermittent, or acute. And again, the PCA muscle exhibits decreased activation, that's reduced opening in the vocal folds, while the adductor muscle group demonstrates heightened activity, increased closing, resulting in a reduction of the glottic aperture. So this altered muscle activation pattern in these patients can contribute to adverse changes in airway dynamics and also seem like ILO, ELO as well, and again, could have components as mentioned. Hypocapnia, and again, that's reduced CO2. It's linked to hyperventilation and it has physiological side effects as well. Often you'll hear more neurovascular symptoms, peripheral symptoms, dizziness, faintness, impairment of concentration, tingling, memory issues, numbness, and research highlighting case studies of patients with long COVID. Hadas Galan did a really great article on this in the perspectives as well. Found DB in 88% of patients, and persistent hypocapnia might have contributed to the symptoms of dyspnea, fatigue, chest pain, and cardiac palpitations. Healthy movement for breathing during exercise involves the abdomen and the rib cage actually moving together, not separate. Again, that retractable ball is a great visual. Breathing frequency is often higher and tidal volume is lower in these patients. We need to observe the athletes with these concerns during the athletic movement. And there's a very high incidence of BPD in athletes with ELO, and some patients are suspected to have ELO and BPD, as we know. So observing, there we go. SLPs can still help. So biofeedback to support breathing pattern training, as mentioned. Visuals, kinesthetic tools, alerting patients to the inappropriate activation of respiratory and accessory muscles, inadequate movement of the chest wall, reduced tidal volume, increased frequency of the breathing, increased inspiratory flow rate, breath holding patterns, using mirrors, videos on the phone, stretchy band around the waist, Buteyko belt, retractable ball, resistive breathing trainers, etc., even the hands. There is objective testing here. CPET could be used, spirometry. There's a lot of things here, but to be honest, it can be variable, highly variable for BPD, and there's no real standardized approach. Hyperventilation could be a separate entity. These are some good self-report measures and questionnaires, the Dyspnea Index, the Self-Evaluation of Breathing Questionnaire, and newer NQ. This was originally created to assess hyperventilation symptoms, but it's now widely being used as a valid screening tool for identifying this dysfunctional breathing pattern. Biochemical measures, resting, capnometry, breath holding time to involuntary respiratory motion. And that just means the patient does a normal inhale, exhale. At the end of the exhale, we hold the breath and we time. This can indicate the patient's conditioning and CO2 tolerance. Biomechanical measures, direct observation. More with these, we have the MARM-S, the BPAT, the high-low breathing assessment. But the thing with all these are the patient is seated, the patient is at rest, and so we need to observe the patient in exercise. So Claudio Milstein created one called the Milstein Breathing Pattern Assessment Index. And in this one, we're using the phone as biofeedback video, and we are using a protocol to help the patient identify these patterns that are normal in BPD. And so reference 39, which is the article I mentioned, this has a sample form and a related table to this index. And treatment of BPD. So the goal of retraining therapy is to establish appropriate abdominal breathing mechanics while eliminating ineffective and inefficient upper torso breathing, specifically hyperfunction of the shoulder, neck, and laryngeal musculature during exercise. It's so important to have the patient check breathing all day long. There's a ton of reps required to develop muscle memory and keeping the breathing in mind all day long. It is life. Breathing is life. We want it to always be efficient. So awareness is key. And long-term effects of respiratory retraining therapy are significant based on the research. 3 hallmarks of the plan: to address symptom relief, to establish habituation of the breathing patterns, and providing skills and strategies to recalibrate these responses. Symptom relief, again, lots of ideas here with these techniques. And there can be several ways we approach this, from abdominal breathing control, pursed lips while lying supine, progressing that to pursed lip inhale and exhale, allowing better control of the amount. It's kind of a regulator, the pursed lips. And we kind of progress this with ratios, with exercise, open throat ideas, various demands of the sport. Of note, though, at the bottom in bold and underlined, and this is more Buteyko related, which is, I guess, my bias too, but of note, pursed lip breathing is used during the practice of these respiratory exercises, yes, but nasal breathing is encouraged after proper breathing techniques are mastered and the patient overcomes, these ideas of breathlessness. We want to evolve them to more efficiency, which is always going to be through the nose. Habituation of breathing patterns, again, addressing at the same time or shortly after the first goal, which we just discussed. And so this is more reminders to pay attention to the breathing throughout the day and behavior modification, etc. Breathing wellness activities as we progress to lowering physiological arousal. And this can serve as preventative strategies to help the patient maintain functional breathing in their daily life. So although the technical training in this stage might not be by an SLP, education about the importance and referrals to trusted colleagues is important. And of course, we can do some of these things as well, especially if we're trained in them. As mentioned, my focus with doing this is full body breathing, 360 breathing, side body breathing, resistance-based breathing, using the pursed lips as needed as a variable resistor to have more control. Using a tiny straw as well, you have control over the amount and the opening. The back pressure, because of that resistance, is a good thing, and this can help improve efficiency. Abdominal breathing control, the supine, the weight on the abdominals, even as simple as a book, as I'm sure you've all heard of. Again, lots of options with metering, with seated, standing, moving, running, walking, etc. Making a contract. When are you going to practice? Exactly when? 2 times a day, 10 minutes at a time. Breathing checks all day long, setting cell phone alarm reminders, using keys as triggers for you. Like when I look at my bracelet, I'm going to practice this breathing. This is a little different than the breathing recovery techniques earlier mentioned, where we're going to do those 10 cycles every hour, etc. Of course, calming down, relaxing the shoulders, doing breathing exercise, remembering we're in control. The patient is in control, and helping them to get this awareness of their own power is so important. Changing the straw size can be important, related to air hunger too, helping the patient to tolerate air hunger once they overcome it. It's another Buteyko concept, but it can be very helpful for CO2 tolerance as well. Posture matters, finding the inner ballerina, lifting sternum, helping the patient understand it does affect your respiratory system, your posture, of course, and your voice. Being aware of these things is important. Grounding through the pelvis, the abs, using the right amount of muscle versus too many. I'm going to go through this last bit kind of quick. Asking the parent, again, as mentioned, for videos of the patient, or asking the patient again, maybe doing your own video work or negative practice and biofeedback in a therapy session. videoing the patient normal breathing, spending 2 minutes using the hands or a band or some kind of resistive tool, and then 2 more minutes without the tool, and then repeating the video for biofeedback. Paradoxical movements usually work themselves out once you continue this work in terms of like this kind of thing. If you just start focusing on the 360, practicing in a variety of positions, standing, being on one leg, a wall sit against the wall, bird dog pose on the ground, all kinds of ways to get the patient out of that habitual posture that could be more inefficient. Building and making this part of the daily routine. And to be honest, this is why I go more towards respiratory muscle training at the beginning versus strength training, which we certainly could evolve to. But it's less about strength percentage for these athletes, and it's more about the timing, coordination, and patterning. So that's why I would start more with the muscle training instead of strength training, at least at the beginning. And the idea of open throat inhalations, down and out, in and up with the breathing pattern. Awareness, developing it into a skill, repetition with exercise, negative practice, asking the patient how it feels, asking the patient which position or which type of breathing can they breathe better with, what are the sensations, those kind of things. Baseline daily function. Oh, these long COVID studies. So when we're talking about this and this DB retraining, addressing the upper airway symptoms in isolation without consideration of the whole respiratory system provided only partial relief of the symptoms. So baseline daily function was only restored after addressing underlying aspects of DB, such as the diaphragm dysfunction and the hypocapnia, with the CO2 tolerance being reduced. All PROMs improved, as well as the biochemical and biomechanical markers in these long COVID studies, as mentioned earlier. The focus was on these things: breathing therapy related focuses, education, rehabilitation of nasal functions, training and education in mindful breath awareness, training of functional relaxed diaphragmatic breathing, correction of hyperinflation using purposeful breath holds, sustained exhalations, reduce volume breathing, instruction in slow and resonance frequency breathing, practice of breath management and control during exertion and speech, different types of feedback, including capnometry, and use of inspiratory muscle trainers. In this study, it was the Power Breathe resistance device, and to the extent of 30 reps twice a day. So these patients reported improvements not only in dyspnea and the respiratory system, but also in other systems as well, showing the impact of breathing on various physiological systems. So that holistic idea that we started with, the unified airway, which I love to also finish with. So optimizing breathing, all these benefits, which we've discussed as well, but it's that whole mind-body connection with breathing. So learning the techniques, various positions, diaphragmatic, full body, posture, capacity. There's a really cool, and again, this impacts lymphatic drainage, circulation as well, pain management. I'll get to the really cool thing in 1 second. Sorry, it's coming up. Breathing exercise improving overall performance and especially lung capacity. General fitness exercises improve and maintain efficiency. And again, that's why healthy body, healthy voice, healthy breath, right? We want to focus on things that promote good whole body fitness, because that's only going to help us, right? And posture does matter. Recreational activities help. We know the diaphragm is connected to the vagus nerve, which releases neurotransmitters that are calming and has a direct connection to the vagus nerve as well. So this is wonderful to practice and tend to. Efficiency of breathing, as we've discussed. This is from that awesome Tabor article 2025. These are suggestions, and this is in the article scripts, ways to elicit abdominal breathing to use with patients if interested. Allowing, I like to say that your body knows what to do, right? Awareness, breathing deeply into the body. This is the thing I was going to say. The number one marker of longevity, based on the Breath book by James Nestor, which I do love, it's lung capacity. So it's our ability of our lungs to expand, and it's our lung capacity that might dictate the length of life in years for us. So the best thing to focus on is breathing, resisted breathing training, expanding our lung capacity, exercise, those kind of things. As you can tell, I'm kind of passionate about that. This also helps your body stay in a calm state to be aware and in control of our breathing, communicating, of course, with the parasympathetic nervous system. And again, slowing down, and there's a lot that gets into this. I do have a course, which I'll mention at the end, that gets a lot into depth of all these things. This is kind of a nutshell, but there's a lot we can do to calm the body, manage that O2, CO2 tolerance, and achieve optimal oxygenation. Lots of different breathing techniques. Breathe to expand, breathe into new places, box breathing, side body stretches, because creating space will allow for more expandability and breathing. Cadence focused breathing. Again, the stretches help you to reconnect to breathing through, but then also prepare space. We can't breathe and expand if we're really, really tight. So this talks to the fascia and the muscles. Again, recommended reading here. A lot of these are more Buteyko based. I think they're all wonderful books. I recommend them to patients as well. Atomic Focus, it has big writing and pictures. It has exercises in there, and it kind of connects to the connection between breathing, cognition with memory and focus and attention, and also exercise. It's a really great one as well. And again, as mentioned throughout, the value of Buteyko, he was a Russian physician who had asthma, and he got himself and all of his patients off asthma meds with these breathing techniques, prioritizing nasal breathing, and so many benefits. But the most basic, filtered, humidified, warmed, moistened air, and about 40% more oxygen uptake through the nose. You can see this video on my VoxFit Instagram, but it's a really good one about all the benefits of nasal breathing. And it kind of goes through that. This is a good recording of Patrick McEwen, who's a wonderful Buteyko guy and author of some of those books. But it just kind of talks about the value of nasal breathing versus mouth breathing.
And here's the relation.
And mouth breathing also impacts breathing patterns and the collapsibility of the upper airway. And this is going back to that OSA, sleep apnea. It has been observed to induce a more thoracic and vertical pattern of breathing and elongates and narrows the upper airway, contributing to the collapsibility. Muscles such as the genioglossus and geniohyoid, which help prevent upper airway collapse, are less active during mouth breathing. So again, the benefit of nasal breathing through the night. Respiratory retraining therapy is very effective in the treatment of BPD, and speech language pathologists are uniquely qualified to assess and treat this condition successfully. Again, research to prove all this stuff. But don't forget to, and here we're at the end, but there's a lot of variety. There's a lot of airway disorders and or conditions that can impact breathing that were not covered today. Some were covered in the previous talk, and they're definitely covered in my course. Subglottic stenosis, Wegener's, sarcoidosis, amyloidosis, laryngeal, mucous membrane, pemphigoid, asthma, exercise-induced bronchoconstriction, as mentioned, edema, angioedema, anaphylaxis, panic attack, all those things we did mention earlier, COPD, bronchiectasis, CHS, PGI, extrathoracic obstructions, mucus, goiter, all kinds of things. So keeping in mind, that's part of that differential diagnosis stuff. And in the previous talk, I did show this video, but essentially it was kind of my strobe showing. I'll show you real quick. My strobe showing a normal exam, essentially. The patient only had breathing complaints, no voice complaints. And then the laryngologist I worked with next did an in-office bronchoscopy, which you'll see in a sec.
You got him.
Now we're going under the vocal folds, progression through the airway. We can see there's a restriction here and narrowing. This spoke to the patient's issues. And essentially this was because of a goiter pressing on the trachea, and the patient did have a surgery shortly thereafter. So the value of, even if the strobe looks normal or the scope does, should there be an in-office bronchoscopy because these symptoms still continue. So we can't forget globus. There are so many reasons someone might have globus, and that can create a feeling of restriction in the throat, of course. These are common reasons. Another video there, but just the value of using your scopes if you have access to them as teaching tools, and even if you don't, pictures, right? Descriptions, videos you find and show the patient, this is still really valuable. It helps buy-in with therapy and their own understanding as well. And we know in the research there's so much value in doing this too. As mentioned, improves patient adherence, understanding, attendance, comfort level, trust. Side note for you, We are occupational voice users as SLPs, so every time you open your mouth, it's an opportunity to choose good vocal habits and prioritize your voice, advocate for your patients, and especially to get scopes if they haven't had one as related to voice and airway. And even if a laryngoscopy has already been done, I recommend the video stroboscopy and that biofeedback, especially in the case of airway patients. It's up to us to advocate for the patients and just kind of think back to, and I always say this in talks that I give, but it is important because the day-to-day grind can certainly stress us out. So remembering your own why, your own mission, why you got into this wonderful helping profession, and reconnecting to that is so important on a daily basis, but especially on those days you might get burnout. So reconnecting to that is it's a privilege and it's a value to help your day to day. No one cares how much you know until they know how much you care. And again, that's a great quote from Dr. Olin, but it's a patient perspective that's certainly important to remember. I also love this and always say this in my talks, but you have to remember you could be the ripest, juiciest peach in the world, and there's still somebody that's going to hate peaches, right? So you can't please everyone, and that's a-okay. You be as authentic as you can, and people will connect to that. It's our job as medical professionals to uphold a mission related to our desire to help people. And lucky for us, it's those things we take for granted all the time, like speaking, singing, breathing, swallowing, etc. So let this mission reinvigorate your passion to work with your patients on a daily. Never underestimate your ability to change someone's life because as SLPs, we are in the business of changing lives. And prioritize your voice. These are my references. And I am happy to take whatever questions anybody has. Thank you so much for your attention.
Hi, Sarah. Thank you so much for an awesome presentation. We have a lot of questions. Before we jump in, a couple of housekeeping items because I know some people have to jump off. This webinar is recorded and the replay will be up on the TIMS website within 48 hours. As Sarah mentioned, this is part of a larger presentation that she does have on her website, so I'll let her speak to that. So for that reason, we don't have slides, but you can definitely go back and rewatch all of the videos and check out the images and her references. If you are wanting ASHA CEUs, we just ask that you complete the brief survey that was put into the chat, and that will also be sent out via email from Zoom. And then last but not least, if you want a certificate of completion, just send us an email at tims-univ@tims.com. And with that, we'll go ahead and jump into some questions. So Carly posted, should people resist a quote catch-up breath or yawn during the 10 practice breaths?
Yeah, that's a great question. And I would say yes, for sure. Because normally, if people are yawning, it is actually a sign of dysfunctional breathing patterns. It's that air hunger, it's a disruption. We actually want to reset. So this is just a side note, it's a Buteyko concept, but there's something called the mini pause technique, and it is to reset the breathing after a disruption, which could be a yawn, a sigh, a sneeze, a throat clear, a cough, anything like that, something like that. You can do the mini pause technique, and I could teach you. It's really simple, but it is to be known if you're, doing Buteyko. But essentially, all you're doing is, okay, there's that yawn. So let's reset the breathing and that O2 CO2 balance. Let's help restore CO2 that's lost by this yawn. Let me actually break it down and say if it's recovering technique, if there's a way we can keep them focused on inhale and exhale, friction-based redirect, keep that going in the 10 cycles, I believe if they're focused on it, they can get through it without the yawn. So keep that in mind for recovery techniques. If it's more BPD DB, I want you to guide them to maybe reset, restore with the mini pause. And that would be keep the mouth shut. You breathe normal breath in the nose, normal breath out the nose. And then at the end of that exhale, you're going to plug the nose. And it's 3 to 5 counts of a purposeful breath hold. For people with COPD, emphysema, even asthma, 3 counts might be more than enough. So cool, do 3, and then you let go, keep the mouth shut, 15 to 20 seconds, and then you can repeat the mini pause. I usually repeat it 3 to 5 times with people, and it restores, and it helps them to be aware of yawns, to give them a tool to reset, or again, size, those kind of things. It actually does things biochemically and mechanically on the inside. So in a nutshell, that's what I'd recommend. Kind of, it's 2 separate things, recovery-based or pattern-based, but that would be my suggestion.
The next question is, do you have any recommendations for inspiratory muscle devices that you use with your patients?
Yeah, of course. So I like the breather voice. or the breather fit. They're essentially the same. This is a muscle pattern trainer. It's a resistive pattern trainer, not a strength trainer. So like when you're doing EMST for expiratory muscle strength training, and again, the adapter for IMST, yes, this is strength training. There's so much value in these, and I love these. But in these patients with pattern disorders or even ILO, ELO, I more often will use the resistive muscle trainers, not strength trainers, at the beginning. And I learned this specifically at these airway conferences, and they're using, breather voice, breather fit, or the power lung, the power breathe. Those two have more advanced settings like for Olympic athletes, etc., giving resistance. There's even other options too, but those would be what I would use in most cases. And then, of course, if they want to get to strengthening later on, then you could further progress to more of those resistance threshold devices, whereas these are more resistive devices.
Wonderful. The next question is, where should a clinician start if you suspect ILO? Can refer for imaging diagnosis, but do not have a scope access regularly for biofeedback?
Yeah, so again, kind of based of what we talked about, you don't necessarily have to capture it on the scope, right? That's really important for the biofeedback and the learning of the patient. But well, I guess I'll back up and say if the patient's never had a scope at all and you're just seeing them, I think it's really important to rule out obstructions, like we mentioned, mobility impairments, that kind of thing. So I would get that done either if it's through an ENT, a laryngologist, etc. It's got to be one of those two, and I would recommend a laryngologist. It might be more comprehensive, or if it's generally ENT, maybe a note on there like, please, without saying weird things like, please get a good views, but really take time to see the patency of the airway, the function during abduction, adduction, etc., because that will give you valuable information. But if that's been ruled out, then you can start, as mentioned, with like therapeutic trial therapy and see if there's benefits in either the outcome measures and the symptoms of the patient and the sounds you hear, those kind of things. But the example of the video I showed at the end with the guy who had a goiter that was pressing on the trachea, etc., and again, I did my strobe, I did all the biofeedback. We did 2 therapy sessions, and I still heard a sound I didn't like, and his symptoms were getting better. And then I wanted the in-office bronchoscopy. And I personally don't care if people think I'm silly for doing those. I think it's so valuable. And in cases like that, we found what was the real reason. So I'd rather be thought of as someone that did a little too much, but explored all the options than not did enough, right? So I would say those are good places to start. Of course, besides ruling out all the other workups that most often these patients come, and those are more often, pulmonary, GI, cardiology. I would say those are the most common ones before they would see you, but there certainly could be more.
Awesome, thank you. And you touched on a couple of questions that popped up in the chat, but one of the questions was, in your practice, who is doing video stereoscopy? Is it you or is it the physicians?
So it's both. It all depends on the day. If the laryngologist is in the office and we're not in a collaborative clinic, they're in that room, so I can't use the scope on those days. But the days they're in surgery, I have full access to the video stroboscopy and the other SLP I work with. So it all depends on the day, what we have access to. But in most cases, we can get one really quick and use it as therapeutic biofeedback. I'll always have a strobe. Either the laryngologist does it or I do it first before I even do anything. So if you're in a setting where that's not possible, just make sure you always get that first. I strongly recommend that. And then, yeah, it just depends on the day, like what we're doing in clinic, whether or not we're doing a scope or therapeutic stuff with the scope. But I do see patients collaboratively with the laryngologist, so that could be the in-office bronch, or I might just, in that patient specifically with the video, I was like, get him in ASAP, and there happened to be a cancel, and we got him in quick, and then luckily he got set up with a surgery with one of our head and neck surgeons. So hopefully that helps answer that question.
The next question is, can you speak a bit more on breathing asymmetry and how we would address this?
Yeah, so asymmetry or asynchronicity just kind of means the ribs, the body, the ribs and chest are not moving together, but maybe the chest is coming up first and then the ribs, or the ribs and the lower body first and then the chest second. We want it to be this 360 idea. So that would be one example. Again, this is obvious to see that shoulder involvement, the extrathoracic tension involvement, the more shallow, rapid breathing, or again, chest involvement. That would be like the asymmetry or asynchronicity. If we're talking symmetry, you might see someone sitting here like this, and that's certainly going to affect breathing. I had a patient today, and I kind of was asking, is this a natural lean? What's going on with the posture? And one of her legs is longer than another because of a car wreck, which affects her hip, which affects her gait, her breathing, her everything in the anatomy, right? So things as simple as that can make a big difference with during your investigation and case history and how you might address that too.
Here is another question. Considering the idea of the normal protective role of the vocal folds, are there ever times where you are cautious about teaching patients to open the airway due to aspiration concerns, such as when food are a trigger or acid reflux is a component?
Yeah. And actually, let me answer that. And I was going to mention one thing about the previous question. The MARM-S, which is one of those investigative tools that involve observation, MARM-S, that's one where you're going to notice asymmetries as you assess, PS. But anyways, yes, related to that, if you're doing a scope or you hear about a scope, if you didn't do it and there were pooling secretions and there was, lack of sensation, or maybe the patient have a history of radiation and their sensation might be down, those kind of things. I'm not going to not teach the patient how to open their airway with a sniff, of course, but it would alert me to be more cautious, right? Or if I'm doing the scope and I'm seeing secretions just headed in and out of the airway, then we know there's another issue there, maybe neurologically or otherwise. So, yeah, that's certainly when those flags would go off for me. Still, we want to help them with their airway if they do have breathing concerns. But again, if that type of a patient was coming in, maybe it is more pulmonary clearance related concerns or deconditioning, or it all depends what's going on with that patient. If we find that it's more related to that and mismanagement of secretions, etc., more EMST would be something I would choose in that case. I can think of an example of a patient who's 21 years post radiation. He's one of our longest survivors in our support group, but during an exam, we were just seeing him collaboratively, and we're just doing some quick kind of trials before starting much and um, related to swallowing. And, you know, just in the larynx, it looked fine. And then the laryngologist I was with was doing the exam. We were guessing his sensation was quite low, and he didn't even notice the scope progressing into the trachea by the laryngologist, not me, of course. And we saw there was blue down there. So in these situations, and again, 21 years post, we expect reduced sensation. Being aware of these things could certainly guide you to your treatment. But related to breathing, we still want to give them tools to open their airway and function. So I guess it kind of depends what's fully going on, which way you would focus. But if they have symptoms related to these three conditions, I would still target that, but just have a little bit more awareness of what's going on. Hopefully that helps.
So we'll take this final question, and then Sarah, I want you to talk a little bit more about your course and how people can contact you, because there were a lot of questions about that.
Oh, cool.
But Sarah posted and said, could you speak to considerations for working with pediatric patients with ILO or BPD?
Yeah, and EILO too. And to be honest, I mostly work with adults, except for airway patients that are kids and or teens and singers. So I kind of love this because I don't often work with kids at all. And you do have to adapt some things depending, how deep you get with explanations. And there are occasions you might need to make things a little more like a game, which again sounds foreign to me because I don't often do peds except in these conditions. But, it's good to stretch us, right? But I would say the youngest athlete I might have had was 7. It was soccer related. I'm sure there's some younger, and I did scope a 4-year-old once with huge vocal nodules, but that's kind of rare. So I would say, in terms of the athletes and these breathing conditions, sure, you can find a younger crowd, and it's really common in teens and young adults. And again, knowing that in a lot of times, based on the research too, it's a little more common in girls. It's a little more common in these perfectionistic type A personalities, high achievers, people that are really, really good in their sport and high level. And again, that could be as young as 10 years old. It could be gymnasts. It could be, there's a lot of sports where there's a lot of pressure, those kind of things. So I would still address everything the exact same ways. You just may not go as deep into explanation. You may keep it more simple. You might use more visuals, more tactile feedback stuff. You might take it slower if you're doing Alobi techniques. I can think of one example of the patient who I think this person was 9. It was also soccer, I think. And Alobi was overwhelming to him. And we tried. He really tried. But I don't know, it wasn't for him. So we tried some of those other methods I mentioned, and those helped him, and he was fine, and he didn't need a Lobi, and he felt better with the other methods, and all was fine in the world. So it's more giving examples, giving tools, not too many, seeing what works for the patient. But if one doesn't work, and don't give up too fast, but we don't want to get them frustrated. So we can kind of guide them to other possibilities to again help them. Did it feel the same, worse, or better? And let that keep guiding you. Hopefully that helps.
Yes, that's great. And I know that we didn't get to all of the questions, we got to most of them. But for those who have more questions for you, Sarah, or who are interested in taking your longer course, would you mind giving them just information about where to access the course and how to get in contact with you?
Yeah, of course. If anybody is interested, because this is obviously a huge passion of mine, I created a course on my VoxFit website. VoxFit's kind of a side business for me, but I have a big Instagram that you'll find a lot of info, research, etc. So if interested, look through that. You can access it through my Instagram. It's VOXFIT with an underscore. There's a link tree on the bio, which you can access the courses. If you're here and you're interested, there is a code, Tim's Talk, one word, TIMSTALK. You get 15% off the course. But you will get all kinds of info in the course. It's very comprehensive. You'll get personal development hours as well, and there's handouts, and you'll get all the slides from today as well, because I added more with our more in-depth with just ILO, EILO, BPD, and the newer research. So hopefully, if anybody's interested, or reach out to me with any questions via Instagram or just my email, info@voxfitconsulting.com. I could also give you my work email, but we'll just stick with that one for now. Happy to answer any questions or review cases or anything like that. Here to help as you need.
Awesome. Thanks, Sarah. And I know we covered a ton this evening. Sarah is absolutely amazing. Definitely follow her on Instagram. I will send out all of the information that she just mentioned about the discount code, her email address, and then, of course, the link to the survey. So that'll be all in the email from Zoom. And then it will also be included in the YouTube description on our website, which will be uploaded in about 48 hours. So with that, we'll close out for the evening. Thank you all so much for being here. And Sarah, thanks again for your time and expertise. We always love learning from you.
Thank you.
Yeah, thank you all so much. Have a good evening.
Bye.
Bye.